Welcome everybody to the November 2023 edition of the JSPS Pathology Grand Rounds, sponsored by the Shanks Foundation and the Pathological Society. Can I remind audience members to ask questions by typing in their question in the Q&A box at the bottom of your screen, please. It gives me great pleasure to welcome today's speaker, Simon Herrington, who is the Professor of Molecular Cancer Pathology at the University of Edinburgh and a consultant gynaecological pathologist. He was co-editor of the 4th and 5th editions of the WHO Classification of Tumours of the Female Reproductive Organs, and he edited the 15th and 16th editions of Muir's Textbook of Pathology. He's a past president of the International Society of Gynecological Pathologists. He's currently Editor-in-Chief of the Journal of Pathology Clinical Research and Editor Emeritus of the Journal of Pathology. His main research focus is the pathological aspects of ovarian tumours as part of the Nicola Murray Centre for Ovarian Cancer Research of the University of Edinburgh. And today he will be giving his Grand Round lecture on the molecular stratification of ovarian carcinomas. Thank you very much for agreeing to speak to us this morning, Simon, and over to you.
Thank you very much, Mark. I'll just share my screen, hopefully. Can you see that?
Yep, that's come up nicely, thank you.
Great, thank you. Well, thank you very much for the invitation to talk to the Society and the broader community today. Gives me great pleasure to be here, and thank you for that very kind introduction, and thank you to everybody for dialing in. So the topic today is molecular stratification of ovarian carcinoma, and what I hope to be able to do in this presentation is to give you some of my views on the current classification of ovarian carcinoma, reflecting particularly on the WHO classification, but then thinking beyond that towards subdivision of those categories of relevance to particularly to patient management. And I think that's the key point here, that we classify tumours in a particular way, often on the basis of morphology and immunophenotype. But there's increasing push, as many of you will be aware, to stratify tumours further on the basis of molecular features, particularly those that are predictive of response to therapy. So with that, the outline of my talk is to start off thinking about the classification of ovarian carcinoma and how that has changed over the years. It certainly changed dramatically in the time of my career. And then focus in on the specific ovarian carcinoma types listed there, with a little bit at the end on carcinosarcoma, which is a tumour type that we have had some recent interest in, and then to think finally about where we might be going from here. So many of you will have seen this diagram before. It was published in 2011, as you can see there. And this really encapsulates the issue of ovarian carcinoma origin. The normal ovary does not contain epithelium, at least not epithelium of ovarian embryological origin. And so it's always been a mystery as to why the commonest tumour types in the ovary are in fact epithelial. And I think this diagram demonstrates why that might be. And the straight answer is that the epithelial tumours of the ovary do not arise from the ovary, they arise in the ovary from epithelial types that come from elsewhere, be it the fallopian tube for high-grade serous carcinomas, endometriotic tissue for endometrioid and clear cell carcinomas, and for many mucinous carcinomas, by no means all, metastasis from the GI tract, particularly the stomach, colon, and the appendix. And we're all very familiar, certainly with the latter concept in terms of clinical practice, where mucinous tumours of the ovary are very often metastatic, classically from stomach. So on that basis, we now have a classification of ovarian epithelial tumours that looks a bit like this, where the serous tumours are thought to arise from the fallopian tube. The evidence is strong for high-grade serous carcinomas. It's weaker for low-grade serous carcinomas, but there is little doubt that those tumours are lined by serous-type epithelium, and it's difficult to conceive of where else they have come from, even though the evidence that they have directly arise from the fallopian tube is perhaps not strong. Importantly, low-grade and high-grade serous carcinomas are now recognised to be different tumour types, not simply different grades of the same tumour. And it took a very long time for that to be accepted. Not that long ago, we were talking about grade 1, 2, and 3 serous carcinomas. And certainly in our review of the ovarian cancer database in Edinburgh, going back to the 1980s, it's not uncommon from historically to see tumours grade 1 serous papillary cystadenocarcinoma that actually turn out to be high-grade serous carcinomas, for example. There's then a group of tumours that arise in association with endometriosis. We can't always identify endometriosis. There are a number of reasons for that, not least perhaps the tumour has outgrown its origins. But endometrioid carcinomas, clear cell carcinomas, and this entity of seromucinous carcinoma that I'll come back to later on in the talk, now recognised by the WHO to be a variant of endometrioid carcinoma, hence now in yellow. And then mucinous carcinomas when primary and malignant Brenner tumours, unclear what their origins are. Malignant Brenner tumours, very rare indeed. Mucinous carcinomas more common, but the precise origins unclear. I'll come back to mucinous carcinomas a little later and talk about their molecular features. And then carcinosarcoma sits down here. Very difficult to know where to put carcinosarcoma, but as you'll see later on, the majority of carcinosarcomas have a high-grade serous carcinoma background, but a significant proportion endometrioid carcinomas. And in fact, in our series, we have one tumour that was originally reported as a mucinous carcinosarcoma, but on review is actually a high-grade endometrioid carcinoma with mucinous differentiation. So I think it kind of sits down here. It's been known for a long time, again 2011 here from Bob Kerman and Yiming Shi, that these different tumour types have different molecular changes, particularly at the DNA or genomic level, with high-grade serous carcinomas being almost defined by the presence of p53 mutation and consequent chromosome instability. Inactivation of BRCA1/2, which I'll expand on in a minute, is an important component of this, but is not present in all of these tumours by any means. Low-grade serous carcinoma is quite different. They don't have p53 mutations. About 2/3 of them have a RAS or a RAF mutation. The other third, still not clear what's going on from a molecular point of view. Clear cell and endometrioid carcinomas, I'll expand on a bit later. They clearly share their origin from endometriosis in many cases, and they do have a similar spectrum of mutations within them, but it's emerging now that there are clear differences between these two types. And then finally, even primary mucinous carcinomas of the ovary often possess KRAS mutations similar to their GI counterparts, but I'll come back to that too. The diagnosis of ovarian carcinomas has really been refined over the last 10, 15 years or so by the use of immunohistochemistry. And you'll see again, papers from 2010, 2014, describing how one can sort out these carcinomas using a relatively limited range of immunohistochemistry, which most of us now use on a routine basis. WT1 being key in this, positive tumours are serous, negative tumours are not. And then using hormone receptor expression, HNF1 beta or napsin, some people will use, and p53 immunohistochemistry then to sort them out into endometrioid, mucinous, clear cell, high-grade and low-grade serous carcinomas. That all sounds very straightforward. Of course, in practice, it isn't always straightforward, particularly, for example, p53 immunohistochemistry, which can on occasions be problematic. But as a general rule, this kind of approach is now routine in the diagnosis of ovarian carcinomas and allows us to separate them into those basic pathological categories, which do have some clinical implications in terms of management of the patients. Now, turning to these individual types, I'm now going to try and flesh them out a little bit and talk about how we might see groups within those types as defined using those biomarkers and the morphology. So high-grade serous carcinoma is familiar to us all. Here's a typical example, some biopsies, in this case, infiltrated by a papillary tumour comprising highly pleomorphic malignant cells. The WT1 positive not shown here, and high-grade serous carcinomas are virtually by definition p53 mutant, and by immunohistochemistry we have these two predominant patterns, p53 aberrant diffuse with overexpression, stabilization of p53 protein, and aberrant null, where there's complete absence of positivity in the tumour cells, whilst there's good normal expression in the surrounding stroma. And that accounts for most of the aberrant patterns. There is a cytoplasmic pattern, which is much less common. So making the diagnosis of high-grade serous carcinoma is usually straightforward. Now, within high-grade serous carcinoma, there are a number of molecular subgroups, the best known being those tumours that are BRCA mutant, whether that mutation is germline or somatic. And about a quarter of high-grade serous carcinomas are BRCA mutant. And BRCA testing is routine, certainly in Scotland, for all patients with a diagnosis of high-grade serous carcinoma. There is obviously ongoing debate about whether BRCA testing should be performed in all non-mucinous carcinomas of the ovarian, and we can debate that. Why is this important? Well, the patients with tumours that are BRCA mutant have a superior survival. They have a better response rate to platinum-based chemotherapy. And importantly, and what has driven the testing, is they show sensitivity to PARP inhibitors. And these PARP inhibitors, such as olaparib, are now part of routine care. But I would make the point, using these references down here, that it's over 20 years since the idea that you might use a PARP inhibitor in this context was first put forward. And this Journal of Clinical Oncology paper this year as the solo trial, which has shown that these can be used as first-line therapy. So this is just a nice example of how translational research takes a very long time. So BRCA mutation, or BRCA-ness, because there are some other molecular abnormalities that produce a similar phenotype to BRCA mutation, is important because it has an influence on the management of patients. But we can go a bit broader than that and now start talking about homologous recombination deficiency. So there are other molecular changes that can produce homologous recombination deficiency and with it sensitivity to PARP inhibitors. And here on the right, you see HR deficient tumours with BRCA mutation, BRCA methylation with silencing, involvement of RAD51, amplification of MC, which inhibits BRCA, and then there's this group of non-specific, non-BRCA homologous recombination gene mutations. And then on the left, you'll notice that around half of high-grade serous carcinomas are not HR deficient, they're HR proficient, and they have a different constellation of molecular abnormalities. One that I'll draw your attention to at this point is cyclin E gene amplification, seen here in yellow, which occurs in a smaller proportion of these tumours, but is associated with poor outcome, and I'll come back to that later. Same is true of retinoblastoma and neurofibromin loss. So it's clear that high-grade serous carcinoma is not one disease. There is a lot of interest at the moment in HR testing or HRD testing, and I just put up this one recent paper from one of the Society's journals from Challing-Boss and colleagues, looking at RAD51 testing as a way of identifying or splitting high-grade serous carcinoma into these two groups, which has implications for therapy. Okay, so that's high-grade serous carcinoma. What about low-grade serous carcinoma? Now, for low-grade serous carcinoma, I've said already, this is a different tumor from high-grade serous carcinoma. It would be better if we had a clearer nomenclature for this, but I think it's sufficient for the time being to know that they are different tumors. And we have done some work on low-grade serous carcinoma, and there have been quite a lot of publications in recent years on this entity since it was defined by Anaïs Malpica and others in about 2004, with her seminal paper in 2007 showing that you can use nuclear grade to separate low and high-grade serous carcinomas. But again, not all low-grade serous carcinomas are the same. And here's some data from our work showing that the presence of a micropapillary invasion pattern, which we know from other sites is associated with aggressive behavior, is also associated with aggressive behavior in low-grade serous carcinomas, as is the presence of desmoplasia, as is the absence of PR expression, which in our hands was more predictive than ER expression. Whereas the presence of a macropapillary invasion pattern, where the invasive tumor has fibrovascular cores, that shows no predictive effect for outcome. So starting to see that not all low-grade serous carcinomas are the same. And similarly, from a molecular point of view, again, from our data, you can see that KRAS mutation and BRAF mutation account for a proportion, but by no means all. And if you use, in this case, whole exome sequencing to try and split low-grade serous carcinoma into groups, you can see from the Kaplan-Meier survival plots that you can do so on the basis of molecular features, as are listed here on the left. So canonical MAP kinase mutations are associated with a good outcome, whereas if you have a tumor that shows chromosome 1p loss and 1q gain, then the outcome is worse, and we're currently interested in trying to work out why that might be. If you have other MAP kinase associated mutations or wild type for all of the MAP kinase associated genes, then again the outcome is worse than in the presence of canonical mutations. So we're beginning to tease out this entity into different types. Why does that matter? Well, some of you will be aware, I'm sure, that the use of MEK inhibitors is now in the clinic. There was the LOGS trial, the low-grade serous trial, showed efficacy of MEK inhibitors in the context of recurrent low-grade serous carcinoma. And there's a lot of interest in developing therapies based on the MAP kinase pathway for these tumors. So the identification of molecular abnormalities that can predict response will likely become important in the next few years. Okay, moving on then to endometrioid carcinoma. And here we are again with this figure showing endometrioid carcinoma as one of the endometriosis-associated tumors, with seromucinous carcinomas now being subsumed into the endometrioid category. You'll all be aware that endometrioid carcinoma is associated with endometriosis, endometrioid hyperplasia, in some cases Lynch syndrome, and I'll make a comment or two about that in a minute. Sometimes you see borderline endometrioid lesions such as adenofibromas or atypical hyperplasia EIN in endometriosis, but in my experience that's quite unusual. Benign adenofibromas and benign endometriosis are quite frequent, but their atypical counterparts are not. Squamous and mucinous differentiation can be diagnostically helpful because they, particularly in high-grade tumors, because they help to push you in an endometrioid direction and away from a serous direction. And of course, synchronous endometrial carcinoma may be present. And there's been a shift in our thinking about those tumors, with the WHO classification suggesting some guidelines, which I'll come back to. So this is a typical endometrioid carcinoma, quite different from a serous carcinoma, smooth luminal borders, often ciliated epithelium, forming glandular structures, and a typical immunophenotype, Vimentin positive, ER positive, CA125 positive, and importantly, WT1 negative. Now, we carried out a study a few years ago now on a cohort of 112 endometrioid carcinomas after careful pathological review and use of WT1 immunohistochemistry to exclude serous mimics, which has in the past been a significant problem in studies of endometrioid carcinoma, where high-grade serous carcinoma with a pseudoendometrioid appearance have been included. And this is an unsupervised clustering map based on the top 100 mutated genes within the tumors. And you'll see straight away that there's a cluster down here, which is basically P53 mutant tumors. And there's another slightly looser cluster up here, which is based on beta-catenin mutation. So this is unsupervised. This is agnostic. We haven't told the algorithm what to look for. It's just pulled these out on the basis of similarity. And when you look in more detail at this, you see that there are essentially three groups. So there are those that are P53 mutant, and then the P53 wild type tumors can be split into two based on whether there is or is not beta-catenin mutation. And these separate out quite nicely on the basis simply of mutational presence or absence. And you'll see beta-catenin is the commonest mutation, with PI3 kinase, then ARID1A, PTEN, KRAS, and P53 in that particular group. Now, you may say, well, what about the PROMIS algorithm that we use for endometrial carcinomas? Where's POL-E? Where's mismatch repair? POL-E is here, and it's present in 6% of tumors. There are 7 mutations here, or 7 mutant tumors, and actually only 3 of them have a mutation in the exonuclease domain of POL-E. so would be considered to be pathogenic in current Pol-E testing in endometrial carcinomas. So that's 3 out of 112. And if you look up at the tumour mutational burden plot up here, you'll see that at least some of these have a high TMB. So they probably are real pathogenic Pol-E mutant tumours, and that's 3 out of 112. So turning to promise, you could then argue that it's worth Pol-E mutation testing in endometrioid ovarian tumours, as well as the current push based on the recent FIGO 2023 that we should be Pol-E mutation testing all endometrial carcinomas. In terms of mismatch repair, we saw mutations in mismatch repair genes, but in a relatively small number of tumours, and very often in non-canonical mismatch repair genes, i.e. not MLH1, PMS2, MSH2, or MSH6, although we did see some mutations. And I'll come back to that a little later. So there we have the frequent mutations, and there is Pol-E. What about outcomes and subdividing tumours, the stratification, if you will, of these tumours? So we had 112, 29 were P53 mutant, the rest were not, and then we split them on the basis of beta-catenin mutation. And the Kaplan-Meier plot shows quite clearly that patients with P53 mutant tumours do badly. Patients with P53 wild type, and interestingly, beta-catenin mutant tumours do well. And those that are wild type for both are somewhere in between. And you can actually split the wild type group a little bit further on the basis of genomic complexity, with one group showing 80% 10-year survival and the other 50%. So we're starting to see, again, subdivision of endometrioid carcinomas. And in our hands, this stratification was independent of grade, which I think is interesting, because I think we're beginning to realize that there are some apparently grade 1 tumors that behave aggressively, and we all recognize that in clinical practice. We sometimes get a surprise with a high stage endometrial carcinoma that is grade 1. We also looked at hormone receptor expression and its relationship to these groups, and PR turned out to be highly discriminatory. So P53 mutant tumours were generally PR low to absent. The wild type beta-catenin mutant group, the good outcome group, was PR high, and the other group was somewhere in between. And it was more discriminatory than ER, for which there was much greater overlap. And so we reasoned that perhaps PR could be used as a surrogate marker of this molecular subgroup. And when you look at PR and P53 mutation status, that's exactly what you see. So the PR immunohistochemistry can act as a surrogate for beta-catenin mutation and produces the same 3 groups by outcome in both disease-specific survival and in progression-free survival. So what this means in practice is that, in theory, at least, we can use 2 immunostains to separate endometrioid carcinomas into these 3 groups. Just a word about synchronous tumours. The ESGO-ESTRO-ESP risk stratification guidelines, which were adopted by WHO, are as you see on the screen. So to be considered synchronous primary tumours for patient management, and that is the key point. This is not about biology, it's about patient management. Then if both are endometrioid and low grade with the Scully criteria fulfilled essentially, and both FIGO stage 1A, which is really quite a restrictive criterion, then they're considered as synchronous primaries. This is creating some issues clinically, which we can talk about, but those are the current WHO recommendations. Okay, a few words on clear cell carcinoma. Clear cell carcinoma, again, is often associated with endometriosis. It may also be associated with endometrioid carcinoma in a mixed tumour, and this is one of the rare situations in which true mixed tumours occur. The differential diagnosis of a clear cell carcinoma includes high-grade serous carcinoma with clear cells, which we're all very aware of now, since the introduction of particularly of WT1 immunohistochemistry. But at one time, a lot of tumours were called clear cell carcinoma that on subsequent review are clearly not clear cell carcinomas. And this is a problem because a lot of older trials and pathology papers are contaminated by high-grade serous carcinoma with clear cells. And I think it's only really now that we're being able to generate data based on pure, correctly classified clear cell carcinomas. Similarly, low-grade serous carcinoma, when the tumor is extremely papillary, can be difficult, but immunohistochemistry usually sorts that out. And then, of course, endometrioid carcinoma with secretory or squamous change, and they can really mimic clear cell carcinoma quite closely, and of course, they're WT1 negative. So they can present issues sometimes. The diagnosis is straightforward when classical, and many would argue you don't need immunohistochemistry when it's morphologically classical, but you can support that diagnosis with the immunoprofile you see there. P53 is often, in most papers on clear cell carcinomas, it will say P53 is generally wild type, and that's true. In our series, we found around 5% were aberrant and contained a P53 mutation on sequencing. You'll see other series that are up 30–40% of clear cell carcinomas being P53 mutant, but that probably speaks to the issue with high-grade serous carcinoma with clear cells. Typically ER/PR negative, which is often helpful. And until relatively recently, we thought of clear cell carcinoma as the triple negative of the ovarian tumor world, WT1 negative, ER/PR negative, P53 wild type negative for mutation. Now, of course, we have the positive markers, NAPSIN-A and HNF1 beta, which are helpful, but I would just add a note of caution that these markers can be false positive in other situations. You can even see positivity in normal endometrium, for example. So here are some examples. This is a papillary and a tubular-cystic clear cell carcinoma, WT1 negative, P53 wild type, ER negative, NAPSIN-A, HNF1 beta positive. This is an example of a tumor where you might think, oh, could it be a high-grade serous carcinoma with clear cells? It was WT1 negative and HNF1 beta positive. Clear cell carcinoma is an odd tumor in that low-stage disease, which most of the tumors are, has a good outcome. But high-stage disease has a paradoxically poor outcome. So disease, particularly stage 3 and 4, has a poor outcome. The therapy is suboptimal. The current guidelines are that from stage 1C2 upwards, patients should receive adjuvant chemotherapy, but it often is poorly effective. And so there's a need to understand whether there are subgroups of clear cell carcinoma that might predict or presage that poor behavior. And the front runner in terms of splitting clear cell carcinomas into molecular types is ARID1A. And you'll notice that's different from endometrioid carcinoma. So we're starting to see differences between endometrioid and clear cell carcinoma. ARID1A mutation in 40–50% of cases. These are our data, as yet unpublished, showing exactly that. And the PI3 kinase mutation occurs in both ARID1A mutant and not. There is an immunohistochemical approach to identifying ARID1A mutation through loss of protein expression. So this could be applied. And there are therapies based around ARID1A mutations. So this is, I think, an area that will develop in the next few years. There has been a flurry of publications on clear cell carcinomas in recent years. So I think we will see some movement on the classification of these tumors. Okay, a couple of words on mucinous carcinoma, which sits over here where we don't really know what the origin is. There was some thinking at one time that they might arise from the so-called tuboperitoneal junction, which is where we see the Walthar's rests, and you can see mucinous tumors arising in association with Walthar's rests, but that hasn't really gone anywhere in terms of certainty. Mucinous carcinoma. So here's seromucinous carcinoma. Again, this until WHO 2020 was considered a separate entity and a variant of mucinous carcinoma, but the association with endometriosis and the molecular features of these tumors, as reported in this paper cited at the bottom here, really led to this being considered a variant of of endometrioid carcinoma. And this is analogous to the thinking in the endometrium, where endometrioid carcinomas with extensive mucinous differentiation are now considered variants of endometrioid carcinoma. That's supported by the immunoprofile, which is often very helpful in distinguishing them from the intestinal type tumors. The intestinal type tumors are quite different. they are negative for the typical gynecological tumour markers. And HER2 testing may be of value, which I'll come on to in a second. So what about the molecular stratification of mucinous carcinomas? Well, we're not there yet. We're not doing any of this really, with the exception in some circumstances of ERB2 or HER2 testing and looking for HER2 amplification, because the therapeutic options in these patients are very limited. And certainly our oncologists will ask us to look for HER2 amplification in patients with mucinous carcinomas of putative ovarian origin for whom the options have been exhausted. There's also a growing interest in P53 mutation. We didn't really know about this until fairly recently because we weren't testing these tumours. But if you do P53 immunohistochemistry on these tumours, you'll find mutant patterns, or aberrant patterns at least, in a significant proportion, over 50%. And it's unclear as yet what that means, whether it does identify more aggressive tumours or not, and time will tell. Okay, so finally, I talk a little bit about carcinosarcoma. This is very much an orphan tumour. When you talk to the clinical people, they just consider it to be a highly aggressive form of high-grade serous carcinoma. That's the traditional view of this tumour, and for which therapy is limited. And of course, most of the literature is on uterine carcinosarcomas, which are much more common than ovarian carcinosarcomas. But we have reviewed all of the carcinosarcomas in our ovarian cancer database going back to the 1980s. We've got 82 properly curated cases. This was, in fact, a lockdown project for me, where I sat in this very room with a microscope attached to Teams and reviewed all the slides digitally with one of my colleagues, and we went through all of the pathology and the reports and pulled out all of the salient features, as you'll see shortly. And these are not just high-grade serous carcinomas with a sarcomatous component. A significant proportion have an endometrioid epithelial component, and whether they have a high-grade serous-like or an endometrioid-like epithelial component, they're associated with poorer outcome than high-grade serous carcinomas, stage for stage. So they are highly aggressive tumours. And this raises the question of whether you can use some of the molecular features that are present in these tumours to identify in high-grade serous carcinoma or even endometrioid carcinoma those tumours that are likely to behave more aggressively, and then consequently look at those molecular features to see if there are novel therapies that can be applied to patients with this really devastating tumour type. And on the left, you just see some examples of a WT1 positive tumour, WT1 negative endometrioid tumour, some chondrosarcomatous differentiation, rhabdomyoblastic differentiation, and here this one was a liposarcoma, and then squamous differentiation, which I'll mention in a minute. So this is the clinical pathological review, and you'll see the epithelial type in the vast majority was serous, but a significant minority endometrioid. The sarcoma type was homologous and heterologous in roughly equal parts. P53 mutation was extremely common, but not universal. We had a couple of liposarcomas, which interestingly both were associated with an endometrioid epithelial component. Here's the squamous differentiation, and just draw your attention to this one here. So this is a WT1 positive high-grade serous associated carcinosarcoma with a serous tubal intraepithelial carcinoma, a stick, and it also shows squamous differentiation. So this is well recognized in other sites that squamous differentiation can be a feature of metaplastic carcinomas, which is what these are. And so if you turn that round, squamous differentiation does not automatically make a tumor endometrioid. So I think this is really just the landscape of what we saw in our cases. We've looked at a subset of these from a molecular perspective, just to try and tease out what's going on in these tumors, particularly in the two components. And I'll just run you through this slide. So the first observation is that the cyclin E amplification subgroup of high-grade serous carcinoma, which you see here on the right, is overrepresented in carcinosarcomas. So a much higher proportion, 50% of carcinosarcomas have cyclin E amplification. Now, whether this is cause or effect, we're not sure, and we're obviously interested in pursuing this in terms of what's going on here. Is it that cyclin E amplified high-grade serous carcinomas are more likely to develop into carcinosarcomas, and that is part of their aggressive behavior? And if so, perhaps cyclin E amplification is a molecular marker or biomarker that can be used to develop therapeutic interventions. Down here at part B, the correlation analysis simply shows that the copy number variation identified in the carcinoma and sarcoma components correlates much more highly in the paired tumors than if you treat them as unpaired. So that means that the individual tumors, their carcinoma and sarcoma components, are more closely related than the individual carcinomas across cases. Perhaps that's not surprising, but it does show or underscores the idea that these are actually metaplastic carcinomas. Now, what we did see was enrichment of SARC copy number and GNAS RNA expression in the sarcomatous component. And that's really just a fancy molecular way of saying this is epithelial mesenchymal transition. This is EMT going on here, because these are both entities that are associated with EMT. Copy number alteration is quite interesting. So this shows, I think, graphically that the carcinoma and sarcoma component here from tumor pair 5, very similar, if not identical. Similarly for pair 11, carcinoma sarcoma, but if you go carcinoma to carcinoma, they're clearly different. And interestingly, the X chromosome seems to be involved very frequently in copy number alteration in these tumors. And you can see here, for example, complete loss of the X chromosome in this sarcomatous component of a carcinosarcoma. And it may be that the X chromosome has a role to play in this context. When you start to look at a more phenotypic markers such as microRNA, and we also did transcriptome analysis, and it shows the same thing, what you see is clustering not by tumor pair, but by component. So the epithelial components all cluster together and the sarcomatous components all cluster together. Again, you could have predicted that because they are phenotypically different. So genotype goes with pair, goes with case, and phenotype goes with phenotype, so that whether it's carcinomatous or sarcomatous. Now, does any of this matter? Well, going back to our original study of the clinical pathological features, you can see here that carcinosarcomas present at an older age. But crucially, in this panel here, you can see that there is a stage difference. There are more ovarian carcinosarcomas presenting as stage 1 disease than high-grade serous carcinoma. But despite that, their response to therapy is much poorer. So a complete response is unusual, well, 30%, but progressive disease is much more common. And there's a significant difference in the therapeutic responses, and similarly, a significant difference in outcome, with ovarian carcinosarcomas being associated with very poor outcome and 15% 3-year survival. Okay, so that brings me to a summary slide, and this really just puts together some of what I've been saying. High-grade serous carcinoma, p53 mutation, pretty much universal. We can debate whether it should be universal. That becomes a discussion of definition, essentially. BRCA mutations and BRCAness, homologous recombination deficiency, important for prediction of response to PARP inhibitors. There are subgroups like cyclin E amplification that are associated with aggressive behavior, and cyclin E amplification is enriched in carcinosarcomas, which supports that idea. Low-grade serous carcinomas, different tumor, don't see p53 mutation, see RAS and RAF mutations in other MAP kinase pathway genes, which is driving this therapeutic direction in favor of MEK inhibitors. Endometrioid carcinomas, we can stratify them using beta-catenin and p53, with PR as a surrogate for beta-catenin mutation, with other mutations less common. Lynch syndrome in a proportion, but it's relatively uncommon. And certainly in our hands with our endometrioid carcinomas, we have another series of synchronous tumors. You do see mismatch repair protein loss, I have never yet seen MLH1 PMS2 loss in an ovarian endometrioid carcinoma. The ones we've seen have been MSH2 or MSH6 plus or minus MSH2. And of course, that carries with it a higher probability of underlying Lynch syndrome. Should we be testing all of these tumours for MMR? I think so. We do it routinely for the endometrium. It's easy to do. These are not particularly common tumours, so it's relatively straightforward. And I think the same argument applies for Pol E testing. Seromucinous tumours are now endometrioid, and clear cell carcinomas, commonest mutation is ARID1A, different from endometrioid. So we're beginning to see some clear water between these two tumour types, even though they are associated with endometriosis. And of course, clear cell carcinoma also has an association with Lynch syndrome, and I would again put forward that we should be doing MMR testing on all of these tumours too. And then finally, mucinous carcinomas, mucinous tumours, KRAS mutation is present but doesn't really help. HER2 amplification can be important in some cases, and we do it on a case-by-case basis. And P53 mutation, I think, is very much a watch this space because it may or may not predict responses. The problem in mucinous carcinoma is that the therapeutic options really are not there, even if we know that P53 mutation is an adverse factor. So where do we go from here? Well, we've seen a lot of progress in ovarian carcinoma diagnostics in the last 10 to 15 years. And just this flow chart that I'm showing here again on the right represents an absolute shift in how we diagnose these tumours. When I first started in pathology in the late 80s, early 90s, we were basically calling them all carcinomas with different morphological features. They were all considered to be one disease. And now we have clearly defined disease entities that have implications for patient management. But as I hope I've shown you, we're now in a position to move beyond this and to start thinking about stratification within tumour types, not just for the sake of it, but because that has therapeutic implications and implications for individual patients. And then taking that a step further, once we can stratify these tumours and we know what's happening within them from a molecular perspective, maybe we can identify novel therapies. And we've certainly got some work ongoing in our group looking in low-grade serous carcinoma to see if there are existing agents that can be repurposed to help in the management of women with low-grade serous carcinoma. They're often young women. It's a disease that is relapsing and remitting. The therapeutic options are very limited, largely at the moment to surgery, with some role for MEK inhibitors. That's expanding. So improving our understanding of these types and how they stratify will help us to develop newer therapies, and we can use the biomarkers that I've talked about as predicted biomarkers for response to those therapies. So with that, I'll finish, and I'd just like to thank a number of people and organisations. So Nicola Murray Foundation, who supports the Nicola Murray Centre for Cancer Research, Target Ovarian Cancer and Teneva Scotland, who supported some of this work, particularly the carcinosarcoma work. And then along the bottom, the Cancer Research UK Scotland Centre, of which I am part, which is a pan-Scotland, but predominantly Glasgow and Edinburgh entity, with the NHS and the university, and also the MRC through the Institute of Genetics and Cancer. And here is, it's a bit of an old photograph now, but this is Rob Hollis. You'll have seen his name quite frequently during my presentation. And Rob has been central to the production of the work that I talked about this morning. And Charlie is the oncologist who runs the centre. So thank you very much for your attention, and happy to take any questions.
Okay, thank you very much, Simon. You can't hear the sound of clapping, but I'm sure if we could, a loud sound of a big round of applause for that excellent lecture, which I certainly thoroughly enjoyed. So I'm going to kick off the questioning with my question first, and then I'll go to the Q&A box after that, if I may. Mm-hmm. So in your discussion of endometrioid carcinomas, you talked about using PR as a surrogate marker for beta-catenin. So I just wanted to ask, is there a mechanistic link between the two? Do we know whether the mutant form of beta-catenin affects the expression of PR?
So we don't know. One might postulate that there is, but we had a look into this and we couldn't find anything concrete to support that hypothesis. So at the moment, it's really just an associative phenomenon. But I mean, obviously, one might think of using beta-catenin immunohistochemistry to look for beta-catenin mutation. As we know, that nuclear translocation of beta-catenin is associated with mutations in exon 3, which are the common mutations. But in our hands, we found that was not a sensitive approach. So a proportion of tumors with beta-catenin mutations were identified in that way, but by no means all. And PR was a better diagnostic mechanism, if you like. But in terms of the biological mechanism, there's no formal link, but I suspect there is one, given that they're both active in the nucleus.
Okay, thank you. So I'm going to turn to the Q&A box questions next. So first question is from Raj Janison, and he asks, for BRCA testing in the tumour, do you in Scotland need patient consent?
Well, hello, Raji. Yes, and you can see me, but I can't see you. So BRCA testing in Scotland is still done as a germline test through genetics, and it's done through oncology. And yes, there is a consenting process currently. Obviously, there's a move generally for somatic testing, and we are doing some somatic testing, but we're getting into political territory now of how you go about these testing systems. We had universal BRCA testing, I think, earlier than many other places, and it was done germline, and that's the way it still is, with secondary somatic testing if necessary.
Okay, thank you. So the second question is from Seth Horsey, and Seth asks, is the beta-catenin mutation immunohistochemically sensitive? Which I think you've already touched on. If it is the negativity or positivity that is expected?
Yeah, so it speaks to the comment I made a little earlier. So exon 3 mutations in beta-catenin lead to nuclear translocation of the beta-catenin protein, and that can be detected by immunohistochemistry. It's a relatively straightforward and robust test. The problem is that not all beta-catenin mutations produce that effect. Now, you could turn that on its head and say, well, does that mean the beta-catenin mutations that don't produce nuclear translocation are not relevant, and it's the nuclear translocation of the protein that's important? It doesn't seem to be the case, because our association is with beta-catenin mutation, the vast majority of which are exon 3. We haven't looked at whether immunohistochemistry is more predictive. That would be an obvious thing to do, that maybe the nuclear translocation is what matters, and that would be more predictive, but we haven't done that.
Okay, so there's a potential avenue for further study there, I think. So Raji comes back in and says, excellent lecture with patient clinical emphasis. Thank you. And he asks, where will the recording be available? It'll be on YouTube as usual, Raji. Louisa Moore also commented as an excellent lecture, so lots of praise. And Will Cross says, great talk, Simon. Thank you. I wondered if your proposal for molecular/mutation testing has crossover with the efforts from Genomics England. We can derive MSI status and drivers from their whole genome testing if it was offered as standard of care.
Yeah, so thanks, Will. This issue of should we be doing whole genome sequencing, and there's certainly a push in Scotland to think about whole genome sequencing in high-grade serous carcinomas. Again, that's veering off into the political arena. And of course, Scotland is different from England in many ways, not least in healthcare delivery systems. And we don't have the Genomics England setup, but we do have molecular pathology. And as I say, there is a Pan-Scotland project on high-grade serous carcinoma using whole genome sequencing, and it may well be that we can move in that direction over time. And I suspect that's what will happen.
Okay, good, thank you. So Another question from this time from Chi Thum, who says, if we are moving to POL-E analysis for all endometrial cancers in future, we could probably just add beta-catenin testing on top of that to the NGS.
Yes, well, I think that's right, and that's so. At the moment, I mean, Chi and I work in the same department, so and she's involved in the molecular pathology. But at the moment, we're doing POL-E testing only on high-grade tumours, but the FIGO is pushing us towards doing universal POL-E testing, and and if we're doing molecular testing on all the tumours, putting in a beta-catenin would be relatively straightforward. So yes, I think maybe that will come again further down the line.
Okay, so I'd like to ask another question of my own, if I may. So taking you back to your discussion of the carcinosarcomas, you described the importance of finding cyclin E amplifications as a very interesting marker. Can you say something about what you expect to be the effects, the molecular and the phenotypic effects of cyclin E amplification? The obvious one would be on cell cycle, but I'm thinking what would be the effects on the patterns of differentiation in carcinosarcoma?
Yeah, I don't know the answer to that. I mean, obviously, you could argue that what is happening here is cyclin E amplifies, you get more cyclin E protein, you get a cell cycle effect based around S phase and pushing cells into an inappropriate S phase. That creates genomic instability, and you increase the probability of EMT. So that might be one option. I mean, we know, for example, in HPV-related disease that cyclin E is an important player in genomic instability. So that's just speculating off the top of my head. That would be my suggestion. It is quite a striking finding, and that cyclin E amplified group has been known about for some time, but its association with carcinosarcoma has not been, and that's a kind of new and an interesting finding that I think needs to be followed up.
Yeah, I agree. Okay, so Graham Murray asks a question. He says, many thanks for an excellent talk. Has AI a role in the classification of ovarian tumours?
Well, thanks, Graham. Not yet, I suppose, but there's no reason why it shouldn't. I mean, as we know, you can use AI-based approaches to identify mutations in a mutation-specific manner, or mismatch repair deficiency, or all sorts of other things. So I can see that some of the things that I've talked about could be identifiable using an AI-based approach rather than a molecular approach. I think it remains to be seen which direction healthcare systems move in over time, and it's quite. I mean, this is almost like a Darwinian evolution, isn't it? You see these testing systems appear through local interests and then going off in different directions. Talking to the neuropathologists, I wasn't aware of this, but apparently in Europe, brain tumors tend to be classified by methylation using the Heidelberg system, whereas if you go to North America, they use mutation testing. Why is that? Well, it's presumably because of the way it's evolved in those different geographical locations. And I can see something similar happening in this kind of space as well.
Okay, good, thank you. So Charles Parker, who you will remember from his work in Edinburgh, Charles Parker asks, excellent talk. Do you find that all BRCA genes are equal in terms of prediction of PARP inhibitor response, e.g. in some other tumours ATM mutants are less sensitive?
Yeah, I don't think we know the answer to that yet, Charles. We're really just sort of at the beginning of this story. The others may know different, of course, but I'm not aware of that. The whole issue of PARP sensitivity is an interesting one in the sense that what I'm told is that all tumours have a degree of sensitivity, and that there is an argument going forward as more PARP inhibitors come online that more and more of patients with these tumours should be receiving them on the basis that they get some benefit. Some may benefit more than others, but that some benefit can be had by most. And that, I think, is quite an interesting and potentially important development. You could argue that we could get to a point where we don't need to test anymore. It's a bit like the tamoxifen argument in breast cancer. Just everybody should have it, irrespective of what their tumours are. We'll see. I think this is very much in evolution.
Okay, thank you. So that, in fact, has completed answering all the questions that have been asked, which allows us to finish on time. We have a tradition of finishing before 10 a.m. if we can, so we can let people get back to work after that. So just leaves me to say thank you very much indeed, Simon. That was a really excellent talk. Much appreciated, not just by me, but by a whole range of other people who've asked questions as well. So thank you. We really did appreciate that. Thank you very much.
Thank you. Well, thanks for asking me. Thank you.
Thank you. And that's all for now.